Information for this meeting are available for public viewing on the Herefordshire Council website. The Council will stream this meeting live on the YouTube channel and is also making a recording. Others permitted to film, photograph and record public meetings, providing it doesn't disrupt the business of the meeting. There are no members of the public present currently. In terms of microphone use, for participants in the room, please raise your hand to indicate that you wish to contribute. When invited to speak, press the button on the right of the microphone unit and speak directly towards the microphone. Please remember to switch off your microphone once you finish speaking. Please also ensure that mobile phones, laptops and other devices are turned to silent where possible, please. In terms of remote, we have a couple of remote participants. For those in attendance remotely, can we request that you use the raise hand feature within the system if you wish to contribute and to introduce yourself when called upon. Please note that only board members present in the meeting room may vote on any item. So moving on to item 1, apologies for absence. We've had apologies from Dr Mike Hearn, Herefordshire General Practice, Councillor Ivan Powell, Cabinet Member, Children and Young People from Herefordshire Council, and Tina Russell, Corporate Director for Children and Young People, Herefordshire Council again. Also Councillor Crockett, Chairman of the Healthcare and Wellbeing Scrutiny Committee, wish your apologies to be recorded. Is anybody aware of any other apologies to record? No, thank you. Moving on to named substitutes, I believe that we've got Dr Parry was potentially going to be substituting for Mike Hearn, but isn't present in the room just at the moment. Just moving on to declarations of interest. Do board members wish to declare any interest in any agenda item today? No hands, thank you very much. And then moving on to the election of a chairperson. So the Vice Chair's kindly indicated that she's prepared to chair the meeting. Board members content that without perhaps I just have a nomination, a seconder, and just a show of hands, please. So a nomination, please. Thank you, Mr Mahaffey, and a seconder, please. Thank you, Ms Hall, and all those in favour of James, please show. That's unanimous, so thank you, Ms Ives. We'll proceed on that basis.
Super, thank you very much and welcome to everybody. So I think the first on the agenda is just the minutes from our last meeting. So no matters of accuracy have been notified. So is everybody happy that they're signed as a correct record? So lots of nods, thank you very much. So we'll move on to questions, and we have unusually actually got a question from a member of public this afternoon. Mrs Reed's raised an issue around the breast cancer screening, which takes place in Kington and until the end of May of 2025 in the car park of Morrison's supermarket in Hereford. She's concerned that many women will not travel to Kington, and so what action will health and social care partners take to ensure that breast cancer screening will take place in the future in the centre of Herefordshire in Hereford? So I would like to thank Ms Reed for raising the concerns about breast screening. Any comments around that, or how we might want to think about that?
If I interrupt, Chair, just very briefly, we have had a supplementary question from Ms Reed as well, which I'll just display. If you just bear with me 1 second. And it reads, I appreciate the provision of breast screening in Hereford will be discussed at today's Health and Wellbeing Board meeting. In April 2025, I was informed that Morrison's car park in Hereford and a site in Kington have the required connection to electricity and water, and it would be costly to the NHS to install these at Asda in Hereford. According to the website www.spalmedica.co.uk, the Spalmedica Hereford is a brand new ophthalmic diagnostic and treatment centre located in the car park of the Asda Supercentre Hereford. Will the board take into account these facts when they discuss the matter? Thank you.
Thank you, Ben. So, thoughts, Carol?
Yeah, there is also, as far as I know, breast screening unit at Ross-on-Wye as well. The van that was in the Morrison's car park was removed from Morrison's car park some time ago. I wasn't aware of it at that particular time, but I gather there was a decision made by Morrison's head office or something that they didn't want it there anymore, which I felt was rather strange, bearing in mind that it would probably increase their number of people that went into their shop. So there has been negotiations with Morrison's, and they've agreed to allow it to remain, but on a month-by-month basis, which is not sustainable as far as we're concerned. So we have been in discussions with ASDA, as Mrs. Reid states. ASDA would take the car park, take the van, but it requires water and electricity. I think what she is intimating is that as Spa Medical is there now, there may be an opportunity for the two to have joint water and electricity, because our view was that we didn't feel the cost of installing electricity and water into the site would be quite expensive and not something we felt that we should be having to pay for. If anyone would pay for it, it probably would be NHS England, and I believe they are aware of it, and I think we've had a verbal sort of agreement. We've got nothing in writing. But I think the issue for us was, I certainly didn't know it had been removed from Morrison's when it was removed, and I think perhaps we should have been made aware. And secondly, from my point of view, there will have been, we think, a number of residents in Hereford who would not have had the ability to access the service as far away as Ross and Wye. So if and when we do get the service back to Hereford in a stable situation, that we make sure that the breast screening service recalls the people that failed to attend during that period to enable them to attend in Hereford, so that they do not slip through the net and have to wait another 3 years. I think Zoe knows more about it.
Okay, that's probably a very helpful summary of where we're up to. So we continue to work with NHS England and the screening programme in terms of making this sustainable, long-term, permanent place for the breast screening van that is central. We've been aware that there has been some uncertainty around that, and as Councillor Gandy points out, that uncertainty in terms of the Morrison's car park. We've explored other options with NHSE and the screening programme. ASDA looks like the most viable option, and we can certainly explore whether we can use that post, because at the moment the sticking point is who will fund the utilities post, and NHS England are looking into the funding of that.
Okay, thank you. So I think it's fair to say that there's absolute support that this should remain in a central location. Carol again.
Just to add a point, which I'm hanging this on a hook really, because I can't find anywhere to find it. With regard to the Spa Medical and the ophthalmology, which I think is a very good move, but as the cabinet member for health, I would have thought that I would have at least found out about this, not through a leaflet through my letterbox. In fact, 2 leaflets through my letterbox. Within 3 days, my husband and I got one each. And initially, I thought that this was a scam, as did a number of my residents. And I contacted Zoe, and Zoe knew nothing about it either. And I do think, as a sort of partnership organised group, as we are supposed to be, that we should at least be keeping people in touch if a new service is being set up which is involving our residents that we know nothing about.
Thank you, Carol. I don't know if Simon might want to make a comment on that.
Happy to. Thank you, Councillor Gandy. I mean, it's interesting. I wasn't sure I was aware either that they'd opened it up. It's certainly the way all this works. Spa Medica are an independent sector provider. NHS contracting is such these days that they can basically set themselves up, pass various quality accreditations, and then they can offer their services to patients. Patients need a referral from their GP, but there's a right to choose initiative, and then they send us the bill. So it isn't a case of the ICB asking Spa Medica, please come and set up a new service. We would love you to come and do some extra cataract operations. Quite the opposite, actually, Jane, isn't it? We're a bit worried about how short waiting times are for cataracts and how much volume of activity is taking place. We're working closely though with Spa Medica now to try and put some more control and rigour around the service that they're offering, and try to make sure those referrals that are going to Spa Medica are appropriate and are necessary for patients. But yeah, in terms of the service, I would absolutely agree with you. That should be the type of thing that we're sharing amongst ourselves. But I don't think even the ICB was aware in the first instance that they were developing that new site in that place.
Thank you. So I think in summary then, really supportive of Mrs Reid's point, and I think working hard with NHS England to make sure that we have it relocated. Just in terms of that point about if there are women who've slipped through the net because they haven't been able to get elsewhere, has there been discussion about that, Zoe?
Yeah, so actually I've spoken to the breast screening programme coordinator who came forward straight away with that suggestion. An assurance that those women that were called during that period where it was in Ross, if they didn't attend, then they will be recalled once we've got permanency in terms of the site in a central location.
Super, thank you very much. Okay, so questions from councillors. There haven't been any notified, so we're on to our first substantive agenda item and the Joint Strategic Needs Assessment. So Zoe, Director of Public Health, over to you.
Thank you, Chair. And if we can share the slides. Next slide, please. So, Joint Strategic Needs Assessment, and you can click through so everything's, I think you need to click through 2 or 3 times so everything's on there. Thank you. So, Joint Strategic Needs Assessment is one of the statutory functions that the Health and Wellbeing Board has duty for under the Health and Social Care Act, and there's clear statutory guidance from 2013 that was updated again in 2022. And clearly this is in terms of our population needs, gives a high level summary, and there are elements of this which we have in terms of the Herefordshire structure. So the guidance says that this should be an iterative process, that it should inform our priorities as a Health and Wellbeing Board, but also funding and commissioning arrangements as well, and that strategic planning. So the way that this is formed in Herefordshire is that there is a summary report. So the summary report has been published in February, and the ask of the board is to pay regard to the Joint Strategic Needs Assessment and look about how we embed that across the system. Next slide, please. So I'm sure you've all seen and had time to have a look at the Joint Strategic Needs Assessment 2024 summary, but it's structured in terms of those high-level summaries around population, around access and risk factors and morbidity and mortality, around children and young people, adult health, vulnerable groups and ageing well. So you can delve into each of those chapters and it gives you a good summary and overview of our population, which should help to inform commissioning and service developments. Next slide, please. So the recommendations of the paper are that board formally recognises the publication of the Joint Strategic Needs Assessment that was published in February, and agrees to consider the findings in development of future priorities. So clearly the health and wellbeing strategy is set on what's in the JSNA in terms of our priorities, and continues to be going forward. The board members, most importantly, look at how we facilitate the effectiveness of the JSNA. So this should be not a standalone document that sits on a shelf or on your laptops, but actually how do we bring this to life and really use it to inform our service developments and that whole commissioning cycle. And then finally, that board members agree to engage with the JSNA Strategic Partnership Group. So a more recent development is there's a strategic partnership that looks at the continuing development and improvement of our JSNA. Next slide, please. So then finally, picking up on that point about how can we all facilitate the effectiveness of the JSNA so that we really bring it to life and use it as best as possible for our population and for those service level improvements. So there's already been engagement in terms of places where the JSNA has been presented, in terms of the detail and what that tells us and changes in our population. So it's gone to health scrutiny, for example. There's a forthcoming Health and Wellbeing Board workshop where there's an opportunity to delve into it and have a look at it in more detail, for example, and it's going to the council leadership team as well. So really an opportunity about how can we use this to engage with other stakeholders in terms of what our needs are for our population for health and social care, but also looking for future opportunities to engage people in that conversation as well. And then finally, as I mentioned previously, it's about how do we really use this through our channels to inform not just the commissioning, but the whole commissioning cycle in terms of those service improvements to ensure that actually our services are meeting population need. Thank you.
Super, thank you very much. So, any questions or observations on the JSNA? Simon?
Thanks, Zoe. Always good to see. I was just reflecting, as we move forward, the development of neighbourhood health is going to be really important. So we're going to try and meet different needs, the different needs that different communities have in a different way. I'm just wondering, in terms of the JSNA, what opportunities are there to break the county-wide picture down to a more kind of sub-county, local level that we could then use to work with Jane and various other partners to drive some neighbourhood health development?
Yes, certainly a really helpful question. So I think there's always the overarching what does our whole population look like, but we certainly know from the health inequalities perspective that that really masks some of those health inequalities, so hence the need to really drill down. And even before the neighbourhood health model, we've been doing that through the work with primary care networks in terms of really understanding what that looks like at a more localised footprint. So certainly a commitment to continue to do that, to feed into the neighbourhood health model, to understand the differences and similarities in terms of those neighbourhood populations and really understand where our inequalities are and where the priorities might differ between those local areas.
Thank you. Other thoughts? I haven't got anybody else's hand up. Carol?
Yeah, I mean, I agree with all that has just been said. I think the sort of the rather depressing part about this is the fact that people are living longer in Herefordshire, but actually their poor health is lasting longer than before. So if you look at the figures of 2011, 2013 and compare it with 2021, 2023, in fact, the number of years that people are living with poor health is getting worse. And so we are doing a lot of work to try to prevent people becoming unwell, living healthier, and yet it doesn't seem to matter what we do because people are living longer, and we still are faced with a situation where we've got this growing number of people who are living unhealthily. And I don't know how we square the tribe. I really don't know if we square the circle on that.
Thanks, Carol. And that's absolutely right. And it's Simon's point, isn't it, about neighbourhood health? The neighbourhood health plans are absolutely critical to our future because it is about how we manage demand into the future and make that move from acute to community, which is one of the three big shifts that's going to be in the 10-year plan when it comes out in the next few weeks. And so that linking together of all of our data so we understand those needs and we're able to respond to them in a different way and closer to home and support people to be healthier, all of that, we have to get it right, otherwise we end up with an unsustainable service. And we're seeing that currently, aren't we, in urgent and emergency care, where we've got too many people needing urgent and emergency care for the size of the hospital that we currently have. And so on the basis that you can't build hospitals very quickly, we really have to support that care in the community. So all of this is really linked. It makes it a very important document. We had a really good session at One Herefordshire on it, and also just as a document, it's very readable. It's you know, as one of those, you know, formal documents with lots and lots of information in it. It's a really good document and an easy read. So if anybody wants to read it, I'd recommend it. So some really good work. I just have one question, which was around that joint intelligent forward plan. So the fourth of the recommendations. What does that actually mean?
So is it useful to bring the slide up again? Sorry, Chair. So I'm not sure whether we've still got the presentation. Slide before that. So in terms of, sorry Chair, which recommendation?
It's the fourth recommendation, a joint intelligent forward plan.
So there is a strategic partnership group that is looking at across the system with representatives from different organisations. So very much, if anybody from the board wants to be joining that very much is looking at what's in the pipeline and how we continue to develop the JSNA rather than waiting 3 years for another summary report. So there's already good representation across the board on that, but would welcome, obviously, always more input.
Okay, fantastic, thank you. I'm afraid I can't see your name.
That's all right. Yeah, Kev Crompton. I'm chair of your Adult Safeguarding Board and Independent Scrutiny for Children. I just wanted to compliment the officers putting this together. Somebody like me find this really useful document. And I've had a thing about data, I think some people in this room know, and seeing all the different data that this authority has and something put together. But I just wanted to assure this board that both children's and adults, particularly the adults board, we do use the JSNA. We do cross-reference it with other things. And I'll give you a simple example today. I'll be now going back to the children's board, asking about the unintentional and deliberate injuries to under 15s and the other age groups, which strikes me, it might not be big numbers, a bit of an outlier. So this document helps me cross-reference. And I know that the Children's Partnership is going to start taking that data in from July, so I can tick a box. So I just wanted to say that from my perspective as an independent chair, this is a really useful document, and I actually have read it. Keep it by the side of my bed in case I get bored. Thank you, Chair.
Super, thank you.
I was just wondering, do you have VCSC representation on that group?
I'll defer this one to Charlotte, who's probably much more cited on the representation on that group.
Thank you, Zoe. Yes, although I'm going to defer to Christine, I think that Christine is a member of that strategic partnership group.
Yeah, so I go to that, but also so does Emily Lowe from Talk Community. So we've been feeding into the pipeline plan all the things that we're gathering as a Health Watch, but also mindful of the work that we might need to do to bring in voluntary sector intelligence into the plan. But if you think we perhaps need to do more than that, then we could talk about that.
We'll talk outside.
Yeah, okay.
Okay. Oh, David.
Yeah, there was just a couple of reflections for me really on the data that shows. Councillor Gandy rightly pointed out, it's on page 37 of the reports pack, that over the last 10 years healthy life expectancy has reduced, despite the fact total life expectancy staying about the same, which is obviously a worry. If we scan forward a couple of pages and look at the primary risk factors around ill health and mortality, the diagram in the bottom right hand corner kind of colour codes them, but clearly the top two, high body mass index, high fasting plasma glucose, which is associated with diabetes, they're behavioural conditions, they're behavioural, like smoking and alcohol abuse. They're driven by behavioural conditions. So the first four, or the first three of those high risk factors are all things that really are bang centre in the centre of this board's area focus. So I guess we should be challenging ourselves going forward about what else could we do over the coming 10 years to tackle those issues, because it is about weight, it's about smoking, it's about alcohol abuse, or alcohol use, which is driving those those changes, and we really don't want to see that repeated in the coming 10 years as well.
Yeah, very helpful reflection. And what we know is not just unique to here is a national picture, but really helps to focus the board's mind in terms of the things that are within our gift to have an influence on, and that is no one organisation's responsibility to have an influence on, but very much sits with this board.
Yeah, thank you very much. And of course, it relates back into our children's strategy as well, doesn't it? Where we've seen the sort of levels of childhood obesity, related into this problem. Okay, I don't think there's any further points. So, Zoe, thank you. You've gone through the recommendations. So, could I have a proposer for those recommendations? Carol, thank you. And seconder, thank you. So, all in favour? Any against? Okay, thank you. So I think we're on to the next agenda item then, which is the joint forward plan, really related to this. And David.
Yeah, thanks, Chair. So as you'll see from the headline of the joint forward plan, we talk about the importance of getting upstream with prevention. Is one of the key ambitions of the NHS in this. So just to give you some background to what the joint forward plan is. So the Health and Social Care Act 2012 is the act that required health and wellbeing boards to produce joint local health and wellbeing strategies. And then in 2022, the Health and Care Act, a similar sounding act, required ICBs to work with local authorities to produce an integrated care strategy. In response to that, so there are two big strategic documents, therefore, that we need to work towards in delivering improved population health outcomes. In response to that, NHS England guidance in 2023 required ICBs and NHS trusts to produce a 5-year joint forward plan, as it's called, and that's the 100-page document that's embedded in your reports pack. So I do apologise that it's our plan that makes this pack 340 pages, but it's a big, important plan that really has two key purposes. The first key purpose is for the NHS to describe how it will contribute to the delivery of the health and wellbeing strategy and the priorities set out in the health and wellbeing strategy, and to describe how it will contribute to the priorities set out in the integrated care strategy, which is a joint strategy between health and local government. Alongside that, and what creates the volume around this report or around this plan, is that we also need to outline how we're going to deliver the key priorities set out by NHS England each year. So on a rolling 5-year basis, we go through something called an annual planning cycle, and we get a direction guidance in terms of what we should focus on in the coming year. So the joint forward plan covers all of that, which is why it's 100 pages long. Now, we first published this plan in 2023, and the Health and Wellbeing Board was invited, and is in fact, by the legislation, invited to review and comment on the joint forward plan, specifically to offer an opinion on the extent to which the plan addresses the priorities in the health and wellbeing strategy. So the covering report highlights the key changes, the key areas of refresh in paragraph 6 on what those changes are. And I would just like to highlight that this year's refresh doesn't fundamentally shift any of the purpose and the focus of the joint forward plan from the plan that was previously reviewed by the Health and Wellbeing Board a couple of years ago and refreshed last year. So the invitation is really for the Health and Wellbeing Board to consider whether its opinion is still appropriate in the light of the refresh plan, and if so, to confirm that it's happy for us to publish that opinion as part of the JFP when we publish it at the end of the month. I'm happy to take any questions. The full version is attached.
Thank you very much. Questions? Okay, Carol.
I think the plan is good. Fine. I've some questions around the plan. So under theme 6, which is the high quality patient-centred services for learning disability and autism care. So I sit on the learning disability board and the autism board as well. And very recently, one of the criticisms that were made by the people on the learning disability board was around the fact that they were finding that either insufficient information was being provided to the acute trust about the learning disability of a patient that was being admitted into the acute trust, or if the information was being provided, it wasn't necessarily being completely understood. And so therefore, in certain cases, when dealing with people with learning disabilities, staff were not necessarily dealing with them in a way that they would understand. And there was also still the occasional situation where a patient who was unable to perhaps feed themselves, their food was put on a tray for them, but that was it. They were not. It wasn't actually fed to them. But it was more of a problem around perhaps the members of staff dealing with the patient not taking into account fully the disability of that person, and therefore their lack of understanding of the instructions they were being given or the treatment they were receiving. And as I say, they weren't aware whether that was from the trust itself or whether it was through the GP that made the referral or what it was, but they would like to see some improvement in that.
Thank you. David, yeah.
There's a couple of things that immediately spring to mind. First is that there has been a programme of work going on for some time now on something called the digital flag, which if somebody's got a learning disability or autism or something like that, a flag on their medical record should come up and be clear for people who are treating that person that they've got specific requirements, and that should be taken account of in the provision of their care. So that would be one aspect that we need to make sure that that's working as effectively as possible. The other thing is we've been through a programme over the last couple of years, I guess now, on what's called the Oliver McGowan Mandatory Training Programme, specifically for training frontline staff and in fact all NHS staff in understanding some of the challenges around providing care for autistic people and how we need to change the way in which we provide those services to take account of those autistic people's needs. So I think there's those two aspects that I would flag. I mean, I'll invite Jane to comment maybe from a hospital provision perspective on this.
Yes, and I think it is a challenge. You're right. The digital flag is incredibly helpful, and we do have agreements for some families and some individuals where we've got someone with learning difficulties coming in very frequently, and where they've got a specific care need. So that's all there, so that as soon as the patient comes in again, the member of staff can pull up that care plan. So I think for some people we can give a very good and bespoke service. For others who perhaps haven't been in touch with the services before, then it's obviously not able to do that. But it's an area to continue developing on. And certainly for the frontline staff, particularly in ED, it's something we've spent quite a lot of time creating the training, and we have an excellent learning disability nurse who leads on that and then trains all of the other staff. But still much more to do. Thank you, Stephen.
Obviously, we've touched on the 10-year plan, which is due for publication soon, and obviously the next item on the agenda is changes within the ICB. How do those strategic pieces impact on the ability to deliver a 5-year plan? Because this is coming out before all those changes have come to fruition.
I think perhaps if we take the changes under the next item,
Yeah.
But I guess the question in terms of the 10-year plan coming out and how aligned it is with what we've already got, I think is probably the question, isn't it?
So I'll pick up on one aspect, and then
Yeah.
Simon, you want to come in and share anything more you know about the 10-year plan. But I don't think there is.
It's coming out before the election. It's coming out before the summer recess.
Yeah. It's a good question. We are good at producing long-term plans, aren't we? I think the difference about the 5-year plan is it's a rolling plan, so we do refresh it every year. So clearly next year's refresh will be reflecting what comes out in the 10-year strategic plan. So this is based on what we knew 5 years ago, and we've been refreshing it since. The timing's not great at the moment because we would have liked to have refreshed it after the 10-year plan had been published. but we will refresh it in the 26-27 iteration in 9 months' time once the 10-year plan has been published. So in the meantime, we will carry on working on the priorities that we've got until we need to change direction.
Okay.
Yeah, this is a bit of a thorn in your side, I think, but I shall raise it anyway. At the last, I'm not sure it was the last or the one before, full council meeting we had, and some of the people in the room will be aware, we had a notice of motion regarding minor injury units in Herefordshire. And it was unanimously supported that we needed to have minor injury units in Herefordshire, and I know that that is not the policy of those that have the powers to produce this. So therefore it was somewhat galling to read that in Bromsgrove, which I know very well as I've worked there, 1.6 million has been awarded to enlarge their minor injuries unit, which is only 9 miles from their A&E department at the Alexandra Hospital. Whereas in and they do have minor injuries unit in most places in Worcestershire, because I actually live in far north in Herefordshire, go to the one in Ludlow, but I could go to the one in Tenbury. So from the point of view of our members and our residents, I would like to understand what is so different about Bromsgrove to what it is about Leinster or anywhere else. Are there more people with minor injuries in Bromsgrove and increasingly more people in Bromsgrove, and therefore should you not be perhaps trying to prevent those minor injuries, or is it just that Herefordshire just isn't being considered?
Simon.
Be happy to provide a response. So, firstly, the capital money that was spent in Bromsgrove was a Health and Care Trust decision out of their own capital programme. They decided that the building was in pretty poor condition and it needed some redevelopment to make it fit for purpose for the 21st century. With respect to the Herefordshire minor injuries units, the only difference is the ability of the trust to safely staff it. That's why the minor injuries units in Herefordshire were temporarily closed. That's why they haven't opened yet, because Jane and team have been unable to find a way of safely staffing those units. So you'll understand, Councillor Gandy, we don't want to offer any services that can't provide safe care with appropriately and suitably qualified staff. That is the issue we had in Herefordshire back in 2017, 2018 when these units were closed. I think it was partly, Jane, as well, to do with trying to consolidate some of the safe staffing resources in A&E. I don't think that position has changed in 2025. I think we've got some work to do to work out what the long-term permanent future is for those services. But the only difference between the two counties' provision, there is a difference in volume, of course, because Bromsgrove is a more densely populated area, as you know. But actually, it's about the ability of the people running the service to safely staff it. That is what is dictating what's open and closed, and nothing else, actually.
Okay.
I hear what you said.
Okay, thank you. I think that point about volumes is important, though. And the volumes previously in those MIUs were very small each day. And my guess is the volumes for a population the size of Bromsgrove is probably significantly more.
Yeah.
Right. Okay, any more on this then? I don't think so. So the recommendation is we're asked to reconfirm our endorsement of the refreshed plan, given the updates that have been included in the 25-26 iteration, and to agree any amended wording to its supporting opinion as necessary. I'm not aware that we want to change the wording of the support. So could I have a proposer for the motion? Thank you. And a second. All in favour? Thank you. And any against? Okay, so that's unanimous. So should we move on then? So I think the second part of Stephen's question was around the impact of the changes to the Integrated Care Board. So Simon.
Yeah, thank you, Jane. And I'll provide as much information as I'm able to, but it's fair to say this is a fairly fluid and dynamic situation that I will try and describe to you. So, interesting, Stephen mentioned the NHS 10-year plan. So, yes, the government do intend to publish a new 10-year plan for the NHS. I'm told they intend to publish it somewhere around their 12-month anniversary of forming the government. So I think from memory that was the 4th or the 5th of July. So we are expecting a 10-year plan to emerge from the government in early July, but definitely before the summer recess, which sets out a whole range of ideas, thinking, and what their medium and longer term direction they'd like to set for the NHS. What I'm going to describe to you, I think, is one of the chapters of the 10-year plan that actually the release of the information was brought forward for a whole host of other reasons, really. So we were told in the middle of March that actually the government had decided there would be some fairly fundamental changes to the way the administration of the NHS works. So this is nothing to do with service provision. This is nothing to do with the budgets for service provision. This is all to do with the resources, the budgets, the money that's spent on the administration of the NHS. And that really falls into two elements, really. One, the role that NHS England play. So some of you might remember, I think it was the 2010 general election when there was a coalition government. Andrew Lansley was the health secretary. He brought in a whole host of changes to the NHS, but one of those was he created NHS England that was kind of like an arm's length body that would sit between the Department of Health and the ministers, and it would sit between local areas. So a bit of a buffer really for politicians and ministers in particular to take a little bit more of the direct involvement in the day-to-day running of the NHS. Lansley's white paper at the time, I think, was called Liberating the NHS. It was all about freeing up the NHS to be non-political and to get on with running its affairs. One of the big announcements, though, that we were told in the middle of March is that NHS England is going to be abolished. It'll be cut in size by 50%. What's left will then be brought back within the Department of Health and Social Care. So that buffer that did exist will be removed, and the Secretary of State and the ministers will take a lot more responsibility and accountability for what happens in NHS. So that's quite significant, because I think NHS England employs something like 10,000 staff. It's a lot of people. So a 50% reduction over a period of time is going to be a considerable change. The second half of the announcement then, which is what I'm here to talk about, referred to changes to integrated care boards. So you guys know, me and David work for NHS Herefordshire and Worcestershire Integrated Care Board. There are 42 integrated care boards currently across England. I think the smallest is about 500,000, I think is Cornwall, is that right? Shropshire is the smallest. Cornwall's quite small as well. And the biggest is Greater Manchester, or one of the ones up north, which covers a population of more than 3 million. So you'll see quite a variance in size and scale of the 42 integrated care boards. I think it's fair to say the government are dissatisfied with where the NHS is. They feel they're spending a lot of money, certainly since the pandemic. Health needs have risen, as we've just heard from Zoe. It's very, very expensive to run the National Health Service in the way that we are running it. And also, I think there is a strong debate about productivity. So some more money, investment, but not necessarily more productivity and more output. So some dissatisfaction politically with how all that works. One of the answers to that is they'd like to remove some bureaucracy and administration. They'd like to free up local NHS trusts, like Jane's Trust, to have more accountability and ownership locally. And they want less interference from administrators and bureaucrats, for want of a better word. So part of the announcement was they would reduce the budget for integrated care board running costs, so the amount we spend on employing staff, on having office buildings, on running continuing healthcare services, they would reduce that by 50% as well. So that's actually an average nationally, because everybody spends a slightly different amount. Our reduction in Herefordshire and Worcestershire, as an example, is 43%, and that equates to £12 million that we will have to spend less next year on running the ICB than we will be spending this year and we spent last year. Alongside that, they also published a document about a month or so later, which was called the Model Integrated Care Board. So it sought to describe a different role that they would like integrated care boards to take in the future. They want integrated care boards to be more strategic. They want us to have a greater focus on population health management and some of the things that Zoe talked about, understanding health needs and strategically commissioning. They don't want us to spend any time performance managing or getting in the way of local NHS trusts. They want NHS trusts to be accountable, more accountable in their own right for the outcomes they deliver, for the quality of service that they deliver, for the financial performance they deliver. They don't want me to have to come and explain that to them. They want just to deal directly with the trusts. I suspect that another part of the 10-year plan will talk about different types of NHS trusts that might emerge who can take on more responsibility for the local budget as well. There's been a long debate about things called accountable care or integrated care organisations who in essence for a place like Herefordshire would have the whole NHS budget and would be responsible for coordinating the delivery of services within that and meeting health need and a set of outcomes as well. I think that will be part of the 10-year plan as well. That bit hasn't been released yet. So, faced with the prospect of reducing running costs by £12 million or 43%, we've spent the last couple of months trying to work through just how we could do that. I deliberately mentioned the variability in the size of ICBs at the start because I think that's part of the issue really, that if you have an ICB covering a population of 500,000 or 820,000, which is Herefordshire and Worcestershire, or 3.2 million, which is Greater Manchester, you obviously will work very differently because of the size and scale of your operation. A huge driver of this whole policy is to reduce the variation and the variability. So they want ICBs to cover bigger areas, in essence. I think there is a relevant point which some of the members in the room will be aware of. The government are also very keen on local government reform and local government devolution. So one of the ongoing debates the council will be having is how it will play a part and who it will form a strategic mayoral authority with. So the idea being that just like in areas like Manchester, in the West Midlands Combined Authority, local authorities come together, they agree to form what's known as a strategic mayoral authority, and actually the residents of that area will elect a mayor who will be the person that's responsible, accountable for all kinds of public service stuff. I think the long-term aim for ICBs is that the government would very much like ICB footprints to match strategic mayoral authority footprints. And I think they'd probably like the mayor to have much more accountability and responsibility for NHS health service commissioning, as well as local government and possibly police and crime forces, I suspect, as well. I think the issue that we have in Herefordshire and Worcestershire is we're a bit of a way off knowing what our strategic mayoral authority is going to be. I think Herefordshire is a bit more straightforward because it's already a unitary council, but we border two councils at least, Gloucestershire and Worcestershire, who have two-tier council systems still. They are both heavily embroiled in working out how they become a unitary authority. In both cases, whether they have one unitary authority or two, a north and a south. We've got to let that play out, and I think when that's resolved, I'm sure Herefordshire Council, I know from talking to Jonathan and talking to Paul Walker, there are already conversations, there will be much more detailed conversations around how Herefordshire would form a strategic mayoral authority and what role it would play. So, in the absence of a clear local government devolution footprint, we've got to do something, basically, because I need to find a way of working across a bigger scale and getting the money out. So we were asked a couple of weeks ago to put a plan forward to NHS England showing how we would intend to deliver that. Our plan is we're not going to merge the ICBs. We think it's really important that we keep NHS Herefordshire and Worcestershire, at least for the next couple of years until the mayoral authority debate concludes. But we are going to have to probably have a single set of managers who run our ICB and probably another ICB as well. So our proposal is that we would cluster our management arrangements with Coventry and Warwickshire ICB, keep the 2 ICBs, but have one set of management that sits behind it, and both ICBs will be able to deliver their running cost savings through doing that. So if you think you've got 2 full teams of people working really hard, doing one set of work, actually we're probably going to have to lose almost one of those teams, and we're going to have to keep a single team who will then have to work across a bigger area. That's the most simple and straightforward way of explaining it. That plan has gone forward. The reason we've chosen Coventry and Warwickshire, there's lots of reasons, but the main one is one of efficiency, that we think we can make it work. They're very stable as an ICB in the system. They've got good financial performance. We have one hospital trust group, the foundation group, who run now Wye Valley, Worcester Acute Trust, and 2 of the 3 trusts in Coventry and Warwickshire as well. So from a strategic commissioning point of view, I think that makes it much more straightforward to commission a local place-based model, because I'm very confident that at least 4 of the trusts will definitely be able to do it, and I'm pretty confident the 5th one will as well, because they already have those arrangements. So we put that proposal forward, waiting to hear back kind of this week, maybe next week, from the Secretary of State as to whether that proposal is acceptable. Once we've got a green light to proceed, really over the summer we'll have to start implementing some change processes. They'll have to appoint a chief executive and a chair. We'll have to appoint some directors. We'll have to run a consultation process with all of our staff to deliver that. And the aim being that certainly by the end of the calendar year, early in January, all of those new arrangements in place. And then heading into the new financial year, we're spending £12 million less than we currently do. So I think that's literally all the information I have, but I'm very happy to answer any questions from anybody that would like to know any more.
Thank you, Simon. Any questions from anybody? Did that answer your question, Stephen?
Well, my question now is leading on that is if the previous agenda are talking about prevention, but you're talking about the efficiencies is taking some of the bureaucracy out and giving it to the hospitals. So if the hospitals look after sick people, where's the prevention agenda sitting in this new organisation?
Yeah, I think as a strategic commissioner, the ICB is going to want to pursue commissioning that delivers a preventative agenda. I think there is a second part to this, Stephen, though, which is we've got to get more of the services to take a prevention focus as well. So, we were talking earlier about ophthalmology. Well, actually, we need the hospital ophthalmology services to be doing more with patients to prevent further deterioration. It shouldn't always result in surgery, every outpatient contact. So I think prevention is a mindset across the services. I think there is an element of this which is about just trying to shift that mindset. But yeah, please don't think that the ICB will not be interested in prevention, because absolutely, I think it becomes probably even more front and centre of the approach, because resources are going to be limited, aren't they? Across the board, in all public sector, actually across private sector as well, we are going to have to change the way lots of these services work. We are going to have to shift the demand curve. It is totally unsustainable to carry on with the way we are, creating more and more health need through the wider decisions that we've made. Like this group here, this board here, we have to continue our focus on all of those wider determinants of health, all those things that happen in people's lives, how active they are, where we decide to build takeaways, how we can promote people, a better environment for people. All those things have a huge impact on prevention and wider health outcomes. I don't see any of that changing through this, quite the opposite, in fact.
Thanks, Simon. And I guess I'd come back on that as well, because in a sense, you were sort of to say, well, you give that to the acute hospital. Well, I mean, for Wye Valley Trust, I mean, firstly, it's an acute community provider and also provides public health services as well through its health visiting school nursing services, but also, much more importantly, works very much in partnership with the One Herefordshire partnership, with local authority, with general practice, with all of those other stakeholders. And the whole point of that partnership is absolutely about integrating care and making sure that we're putting as much emphasis on prevention and inequalities as we are on treating acutely unwell people. But I'll take you back to my comments earlier in terms of urgent and emergency care, where at the moment we're swamped with that. We absolutely have to make this shift, because currently the quality of care isn't good enough in a very congested urgent and emergency care department, and so we have to make this shift. So it's absolutely in everybody's interest to do those things.
One quick follow-up.
Yep, and then I've got some more coming in.
Sorry, I don't want to hog the mic, but in terms of the role and function of the VCS sector in terms of helping you with the prevention agenda, it becomes even more important that engagement is real in terms of those equal partner around the table and be part of the solution. That when we talk about co-design, co-production, really embedding some of those principles, there's a real opportunity here.
Yeah.
And I think just an observation from me in terms of trying to get a prevention discussion going is challenging, because time is precious. It's not the resources as such, it's time. But if you're reducing the headcount even further, trying to get those conversations become really important. And people need to make time to really think about prevention and going further upstream, rather than just helping someone manage their long-term health condition better, actually stopping them developing that condition in the first place. Sorry.
Yeah, that's absolutely right. And say that, you know, the neighbourhood health guidelines are really important in that. And as we develop neighbourhood health and those neighbourhood health teams, which absolutely would include the voluntary sector as well. I think you're next.
Thanks, Chair. Appreciate the territory you're in, Simon, former Chief Executive for many years. I know how difficult it is. But my role here is about safeguarding. And you forgive me saying your ICB colleagues currently bring much needed capacity and expertise to the table. If this change at that level, have providers then going to be given the capacity to do that? Or are we all going to have to deliver a message to government, which is you can't have these high expectations around partnership working if at the same time you're putting the pressure on the police, the council, ICBs and change to deliver, you know, more for less. So I do think there is a risk to sustaining partnership on safeguarding in some of this that needs to be just kept on the agenda a little bit.
I mean, if I can just reply, Jane, I couldn't agree more with you. There has been a view that the NHS input into the safeguarding process involves quite a bit of duplication, that we're treading on each other's toes. I'm not sure I see that, but I do recognise and acknowledge that viewpoint. I think the key thing is, Kevin, nobody's changing the law and the legal responsibilities. So what I'm describing is a whole different way of working, but it doesn't change my accountabilities as a chief executive and accountable officer. I take those really seriously when it comes to the safeguarding agenda. Lots of our partnership work with people in the room around things like SEND, Ofsted, improvement, that's not going away. The challenge for me is to make sure I find a way through this that enables us to continue to fulfil those responsibilities and fulfil them well. Because you're right, I think we've seen huge strides forward in safeguarding in Herefordshire in the last 2 or 3 years. We don't want to lose any of those, do we? I totally agree.
Thank you. Christine.
Yeah, just a question for Simon about continuing healthcare. Obviously, you've got a big budget to cut there, and I'm just wondering what pressure that will put on the system elsewhere and shift the demand into potentially adult social care, and how we're going to manage that around delivering the right outcomes for population.
I don't think it will shift any demand at all. Continuing healthcare there's a pretty thorough assessment process that takes place to assess whether people are eligible. You're either eligible or you're not. It's quite a high bar, actually, to become eligible for full continuing healthcare. I don't think it would even be possible to shift any of that demand to adult social care. I think you do hit upon a particular point we are going to have to work through. There is a school of thought, and I do agree that actually giving community health providers more responsibility for the assessment and management process of continuing healthcare, I think is a really good thing. And if I look back 15 years to, we had primary care trusts then, and they employed a lot of the community staff, and the continuing healthcare bill was about a tenth of what it is now, because the community health services found ways of wrapping around patients and meeting need in ways other than commissioning an expensive continuing healthcare package. I would like us to get back to that point, but equally, I think we need to manage that process well. I don't just want to dump it all on Jane and say, off you go. We spend £120 million a year on continuing healthcare in Herefordshire and Worcestershire. It's an enormous amount of money, involving a lot of very vulnerable people, and we've got to find a way of transitioning that safely. But it won't be shifting any cost to adult social care. I don't think that's even possible, actually.
Thank you. Zoe.
Yeah, it's just to take us back to the prevention conversation, and very much in terms of Stephen's point of view about how VCSE play into that prevention conversation as well. It feels like that actually we go through all of these changes repeatedly, don't we, and at a wide system level, and they're inevitably going to have an impact. But I guess for Herefordshire, it's very much thinking about place-based level and thinking about where is the opportunity in prevention at the neighbourhood health model. And therefore, whilst also looking at how we configure services at a neighbourhood level, very much thinking about that prevention, connection with communities, and that's very strongly, obviously, where that connection with the community and voluntary sector comes in. And I think we mustn't lose sight of that, of what we're trying to achieve and how we're trying to achieve it, and that needs to be done at a really localised level.
Just a really quick point, Zoe. I think that's the strength of Herefordshire, is in the place-based kind of ownership and sense of identity. I think we've had a really good 5, 6, 7 years actually in health services here, and the reason it's worked well is because people have really rallied and they've owned that place-based agenda. You're absolutely right, we must use this latest set of changes to capitalise on that foundation that Jane and colleagues have given us, and I think it's really positive because there will be more space for place-based ownership than there has been.
I think it is. I think it is a huge opportunity, and a lot of this just goes back to that urgent care again. That we need to be better at prevention and people looking after their own health, because our urgent care system's under such pressure and stress. Okay, there's no other hands up, so thank you for the update, Simon. I think we just note the update that you've given us. So next on the agenda is update on our one of our health and wellbeing priorities in terms of good mental wellbeing throughout the lifetime, and I think Lindsay McCarty has taken us through this.
Thank you, Chair. I'll just share the presentation. Okay, thank you. Okay, so I will just do a short introduction. So this is an update on the good mental wellbeing priority area. So the paper covers the most recent progress to date. One of the highlights I will make is that we have recently become signatories of the Better Mental Health Concordat, which is really positive. So today we're going to hear about some of our most local project delivery, which supports our good mental wellbeing priority area. So I will hand over firstly to Kate and Charlotte, who are leading the community lifestyle group.
Thank you, Kristen. Good afternoon, everybody. Thank you for having me here today. I'm here alongside Kate Ford from the Assertive Outreach team, who's going to introduce herself shortly. But my name's Charlotte Brants, and I'm one of the team leads in the Healthy Lifestyle Service. And Kate and I have been invited along today to showcase our community healthy lifestyle group that we've been running in collaboration. So I'm going to hand over to Kate for the first part. She's going to talk us through sort of the aims of the programme and the kind of proposal, and then I'll come back to talk about what the programme covered.
Hello, so I'm Kate Ford. So I work for the Assertive Outreach team, which is a specialist community mental health team in Hereford. So our caseload is for people who have a limited engagement with the mainstream community mental health teams, sort of adults from 18 to 65 who have got severe and enduring mental illness, things like schizophrenia or bipolar. Often they've got substance misuse, criminal convictions, non-concordance with treatments, repeated psychiatric admissions, and have difficulty managing their homes or themselves and their self-care. So we offer support so they can stay in the community, so to try and minimise the repeated hospital admissions. And our team have known for a very long time that getting people integrated into the community and their local resources is very challenging for our particular client group. So the rationale for this group programme was for patients on our team find it very difficult to engage in community activities, so they require sort of more intensive support than lots of people. So patients on our caseloads, fitness levels, social skills and confidence mean that they face barriers when attempting to access the mainstream community resources. And a large majority of our patients on our caseload have got very poor physical health. So this is influenced by the fact of their ongoing mental health symptoms, the massive doses of antipsychotic medications that quite most of them are on, the substance misuse, their lifestyle choices. So all of them, most of them smoke, quite a lot of alcohol misuse, which I think you've been covering in some of the other topics. And this programme was initiated as a stepping stone for patients on our caseloads to sort of be educated and get more information on healthy lifestyles and accessing amenities in our community in Hereford. So I approached Charlie from the Healthy Lifestyles team to get some support with setting up this initiative, and our main aims for our group were on the next slide. So it's for a safe and non-threatening environment to engage our patient group in the local community, for them to learn about healthy lifestyles in an enjoyable and a meaningful way, to maintain and improve physical health, fitness and a range of other community living skills like getting to the places and sort of just other general community living skills, to build their self-esteem, so through improved physical health and confidence in themselves, to provide them with structure, routine and meaningful activity for their week, to help them develop positive and pro-social relationships with the staff who are facilitating, other people, other peers who are attending the group, and also sort of people in the public, because we are accessing mainstream activities. And then our final aim was sort of to develop an awareness of amenities for them so that they could access them with us, but then we could signpost and they could continue to access these activities on their own or with support from our team independently after the group had finished.
Thank you, Kristen. So I'm going to talk a little bit around the programme. So as Kate described that particular cohort, we really needed to focus on how we were going to engage these people and motivate them to attend. So Kate's team was responsible for identifying those patients that they felt were suitable, which I think was really key in this. So those that they felt that could maintain the attendance at a 12-week programme. So between 6 and 7 clients would be identified by Kate's team. So we've recently finished cohort 2, but we've done 2 cohorts of this programme now. So it would be a weekly session that took place on a Monday afternoon, and we would base that at a community venue. So it wasn't in a clinical space at the 27A offices, it wasn't in a council office. We wanted it to be really informal and also really accessible. So we actually used the Union Cafe as the community venue for the last 2 cohorts. And the programme was a combination of education as well as an introduction to community groups and services. So the picture on the left-hand side there that someone has drawn is one of the activities we did around the education elements, where the group simply drew what they had for dinner the night before, and it was a conversation starter. So a lot of the education elements we really broke down into sort of fun, interactive activities and kept it quite short and sweet. So we'd be covering fat, sugar, snack swaps, the Eat Well plate, portion sizes, all different topics, but mainly in quite an interactive way. So after that particular activity, we would have a conversation about what small swaps they could make, what changes that could they make based on what they had for their meal the night before. We also did a sugar activity where we did the it's called Sweet Night In, where essentially it's the idea of a takeaway. So you would have a takeaway meal, perhaps some sweets, perhaps some popcorn and some Coke. They actually filled up a bowl that day of the sugar in each of those items, which was well in excess of 600 grams. So they filled a whole bowl between them. And so the actual physical game of doing that and seeing that quite visually So just trying to embed some of those themes around the education in a more practical way. As part of the programme, we really use those existing links that the Healthy Lifestyle Service has with our community partners. So the other images on the presentation there, we took them to play pickleball at the Community Sports Park, which links in with Activate. We had an introductory session to pickleball, which they absolutely loved. We also visited the Growing Local Community Garden to look at volunteering opportunities for them there. We did Tai Chi with Matt Hudd. We visited the Halo cycle track. We had an introduction to Halo. We did barrel bikes. We did an awful lot. And so as part of the programme, we encouraged and supported them to engage with all of these different things that we were throwing at them. And I think for me, that was a big part of what we do. It's that collaboration between the two teams to really enable these clients to attend. And as you can see, the goal setting was quite small for these clients, and actually coming along for many was a humongous goal. So we kept it quite small, but actually those changes would then stack. So if you can put up the next slide, Kristen, I'll talk you through a little bit around some of the feedback. So I think most of the comments there, these all come from the last cohort, cohort 2. They just kind of echo the enthusiasm and also the positivity that the group brought for a lot of people, and also that kind of endorphin buzz from some of that physical activity that they engaged with. There's a picture of a gentleman at the cycle track there. They loved that session, just being outdoors with one another in the open air. A lot of them just said how great they felt after, and obviously really inclusive. So he actually has cerebral palsy, so he was able to use a bike just with his hands that day. I'm conscious of time, so we'll go on to the next part so I can talk a little bit around outcomes. It was really hard, and I apologise for the text on this particular slide. It was in a fancy Talk Community font, which didn't translate very well when it was then added to the slide, so apologies for the difference in capitals. It was really hard to pick a case study actually, but Kate and I chose a gentleman that came to our cohort, cohort 2, who is living in supported housing currently, type 1 diabetic, smoking daily, physically inactive, or was, before he attended the 12-week programme. Kate described someone to me who really struggled to engage meaningfully actually with any community services. And actually through my initial conversations with him, he barely left that small supported accommodation. He'd sleep most of the morning into the early afternoon. So actually getting up and coming along was a huge feat for him. But he was keen. He was ready to start. The door was ajar. He was ready to start those conversations, and he was actually really engaged. Such an active participant, and he attended 10 out of the 12 sessions. And actually, through that, what astounded me the most was the fact that for the Halo cycle track session, he chose to get himself there independently by taking 2 buses. Whereas at the start of the programme, he would have relied on Kate's team for support with actually just getting a lift to attend. He'd actually gone out of his way to walk himself to the bus station and find out how to get 2 buses to the session that day. But he increased his daily water intake, which may seem like nothing. However, this gentleman reported speaking to just drinking coffee and sugar daily. So he'd then come along to the programme with his bottle of water each time, and he'd tell me that he'd cut out a couple of cups of coffee in the week through drinking more fluid. He didn't manage to quit smoking, but through using a regulated vape provided by us, he cut his smoking in half, from 10 down to 5. He was making much better choices after a food label education session. So he would tell me that when he popped out to get his meal deal from Tesco, he would be looking at the labels. He picked up an iced coffee that was full of sugar, which he noticed. So he changed that and picked up a flavoured water. And through those small changes, he felt like his diabetes was better managed. He had more energy. As I said, he was actively travelling to sessions, and as an introduction to the barrel bikes then was asking lots of questions about where's the closest barrel bike to his accommodation so that he could use that to continue to move around the county. As a result of cohort 1, Kate's team actually went on, they have support workers within their team who were able to support these clients to continue with the motivation and confidence following the group. So if they've decided that they'd like to change something or attend something, Kate's team can continue with that support. So as a result of cohort 1, they actually set up a weekly badminton group because so many of the clients loved it and engaged with it well. So this client from cohort 2 will now be attending that badminton group, which I don't think would have happened right at the very beginning. Next slide, please. Kate, feel free to chip in at any point here, but these are just some ideas that Kate and I have that we wanted to put on a page around moving forward. So as you can see, we're in the really early infancy of kind of finding out what works for this cohort of patients and that collaboration, but it's come on a lot in the last sort of 9 months. And so we do have a few ideas around how we would like this to sort of grow and change. I've had recent conversations with Halo around these particular cohort of clients attending the GP referral to exercise scheme, which have been really positive. So I'm keen to continue those conversations to see if we could link these clients up with that for ongoing support with increasing their physical activity. The cooking sessions were a real hit. So, for example, with one of them, it was around embedding so we talked about meal planning and budgeting, but actually we wanted to do that in a practical sense. So we bought mince and vegetables, and I think it came to about £11. And that session was focused on what can we make from that. And we actually went on to make 6 meals. So a really healthy chili and rice and a veg-packed spaghetti bolognese. And so they actually saw then what they could make that was really healthy, that they could have in the freezer for a day that their mental health was quite poor, that then they could just warm up and eat. But the community cooking element of that and the venue that we used, we're really keen to explore that further because we feel it's missing from Hereford Community Services at the moment. Kate and I have had a conversation around expanding it further, just past the assertive outreach team. So Healthy Lifestyles have worked with Oak House before, but we had a bit of a slightly different model, and we're quite keen to offer this particular model that's been so successful with Oak House, who are a supported accommodation for those that are almost that stepping stone to living independently, so it would work quite well. As I mentioned around the support workers, so we've got the badminton group from cohort 1, and I know from cohort 2 there's potential that there'll be a group support workers enabling a group of volunteers to go up to the community farm weekly as well, to sort of continue some of the momentum. So we are really keen to establish and keep those links with Growing Local and the volunteering / potential paid opportunities for clients there from that. Strengthening partnership working. So through mine and Kate's collaborative work, we've been able to get Kate's whole assertive outreach team trained up in Swap to Stop, which is the training package to move people from tobacco over to a regulated vape kit. And through having the Swap to Stop training, Kate's team are now able to provide their patients with the vape kits without having to have an ongoing referral to our team. So that team is now trained up, and we're keen to strengthen that. We're seeing a lot of referrals come to, which is fantastic, because it fits so well, that light touch support for that particular cohort. And also we would like to explore these connections with the living room. That's the venue that we used in Hereford for our cooking session, and it went down really well with the clients, but it's also a fantastic community space. So we were able to introduce them to community larder and other services. And actually at the time of choosing the union, it did have other services there, which it doesn't now. So we're quite keen to consider whether the living room might be a sort of more appropriate central base to hold this, that has wider connections to the local community. I think that's us. If anyone's got any questions.
Thank you. Okay, we'll move on to Millie at the hub now.
Hello, I don't know how to turn that on. Sorry, hello. It's a bit daunting. This is our community space that we built up. I don't really know what to say about it. I was really interested in listening to everyone around the table. I think the one thing that hasn't been mentioned is poverty and how much that affects health. And absolutely, I smoke like a chimney and survive on coffee because I'm working class. My dad drank tons of beer and I think survived on curry and coffee because he was working class. It's brilliant that we want to change people's lifestyles, people's health and fitness. I've got 1.5 lungs and still smoke like a train.
Millie, are we okay to move? Are you okay if I move on to the
Yeah.
Thank you very much.
Click through the.
Thank you. I'll click through, and then we'll move on to Judith at the hub, if that's okay.
Yeah. Thank you.
Okay, thank you. It's always very hard to follow Millie because what she says is so profound, and yeah, it's left me a bit speechless actually. Anyway, I'm Judith and I'm from the Open Arms group in Kington, and we're a community interest company. We're a non-profit, and we set up during COVID in response to young people's lack of any facilities in Kington, and the very evident, including in our own families, mental health issues that were arising from that, including in some cases through poverty, through lack of public transport, which is still a big issue for Kington. It costs £8.90 return from Kington to Hereford. Just drop that in there. So I'll try and get back to what I was wanting to tell you. We've undertaken a lot of local consultations since we set up in 2021, but it wasn't until we managed to take ownership of the Oxford Arms old coaching inn, which had been up for sale, and opened a community space in the courtyard and barn, that we realised the really truly profound extent of unmet social needs within the community, and that spans mental health to loneliness, really, and isolation, and lack of people to talk to, lack of non-judgmental spaces. And that was all, it seems, very much emphasised since COVID especially. People are lacking social opportunities to interact, both for work and also just for social experience. We're 2 years on. We've still not managed to get inside the building open for the public because there's a lot of work to be done. But with what we're able to do in the outside space and in the detached barn, we're seeing the impact that a kind, caring social space, which we're calling a community hub, in Kington can have. And it's far greater and more transformative than we'd actually really originally envisaged. Our aim is quite simple, really, if I spell it out the way that we've thought about it. It's to create a kind and caring space where good things can happen every day, and where people can come together to create those good things. We have found that what we're offering, it is really very formative. There's a long way to go, but we're able to give some access to informal or semi-structured opportunities to interact socially in non-threatening, non-transactional ways. You don't have to buy something, you don't have to kind of commit, you can just come in. And it's not even got a door. At the moment we just have a yard, which has proven to be really interesting in terms of how comfortable people can feel in that setting. We thought we'd be very disadvantaged by not having a fabulous space up and running, but for many people it's actually proving less threatening, more inviting, because they can just peek around the corner of an open yard and see what's going on without actually having that commitment to make, to open a door and to fear that maybe people will look at you, will identify you, will come with a whole load of assumptions about you and your background, your family. Everybody knows everybody in Kington, for anybody that hasn't been there. So it's a very interesting spatial social experience, and something that we're learning a lot from, and we've got more to learn. We've been so fortunate in being able to get some a year's funding through Healthwatch and Herefordshire Community Together to pay for a part-time community coordinator, community engagement coordinator, Kim Greek, who would be here, but she works at Echo on a Monday, so I'm here instead. She's really transformed things and is building up a incredible sense of momentum. She had previous experience as a place of welcome, and we've since November been able to establish a weekly place of welcome. For anyone that doesn't know what that is, there's a lot on the web that you can find out about it. So we open on a Wednesday. We're also open at the weekends. We run a pop-up cafe and a pop-up bar, and we've run over 93 activities, I think it is, and events since June 23. They're almost always free for people, and I've got a huge list that Kim gave me to remind me, but I won't take you through them. You can find it all on our website if you want more detail. But really, the place of welcome is important, because that's just a place where you'll get a cup of tea, cup of coffee, biscuits, and somebody will be there who you can talk to. And we've discovered that it's become something that the social prescriber in Kington really appreciates and values. And she's just last week agreed with Kim that she'll come twice a week and run, twice a month and run social prescribing hub out of that space. But I know you've got lots to do, and I just wanted to share a few of the parts of testimonies that we've sort of gathered together from people that have been coming. We've really seen something that extraordinary happen. I mean, we're all volunteers apart from Kim, and what we're seeing a pattern is people that come because they need someone to talk to, or they're just curious, or they're feeling desperately lonely in some cases and very depressed and anxious. Many of them are actually starting to get engaged themselves as volunteers, and that seems like a perfect example of community engagement if it can come back. And it's entirely spontaneous. It's not something that you don't have to commit to do that. But the examples I want to give, first of all, it's from a man who's in his mid-40s, so we still call him a young man, because compared to people like me, he is very young. He's a dad. He's been diagnosed with multiple sclerosis. It's really wrecked his career. It's almost broken up his family and his marriage. And until he discovered the places of welcome, he was just, as in his words, I was just sitting at home. I was wallowing. Now he's been coming to the weekly place of welcome, and he's actually he discussed with Kim, and he started running sunflower socials himself. He realised that there were other people like him who had disabilities that may be slightly hidden because that he's not yet in a wheelchair. And he said, it's given me a reason not to sit and wallow with my condition. I was craving social interaction, and turning up and being present for other people once a week provides me with a sense of purpose. And he's, just one example, but a really powerful one. Another...
Sorry to cut across you, Judith.
Okay.
Thank you very much, and sorry to cut you short.
Can you just show our 1 minute?
Yes, so we will share, there's a 1 minute video which we will share with you all following the meeting, if that's okay. Thank you, Beth.
Thank you.
Just to finish off the good mental wellbeing priority area, so our next steps, we have a workshop planned for early July with our partnership. At that workshop, we will review and develop the next iteration of the Good Mental Wellbeing Action Plan. So now we're 2 years in, we've got the mental health needs assessment data. We will review our next steps, our actions, and plan to take those forward. Thank you.
Thanks ever so much. It's a shame your colleagues have gone, actually. 'Cause I was keen to ask some more questions of them, but I think they've gone. It was really great to hear their stories from the things that they're practically doing on the ground. It's there's some really extraordinary stuff there, isn't there? Thanks. Lindsay, any other questions? We've got somebody else. Yeah, Kevin.
Kristen, if you give me Millie's details, I'm quite happily follow up on that safeguarding issue. I think not the environment to raise it, but if it's a real issue, I'm sure Helen said the same, because that shouldn't be happening, what she's described. Simple as that, Chair. I just thought I'd clarify that from my perspective, and happy to follow that up if it's possible.
Brilliant, thank you.
Yeah, thanks, Kevin. So you've obviously it really brought it alive, bringing those your presenters in. So we'll sort of take it as read the documents in the paper in terms of where we are against the strategy that we set. And I think as part of our workshop in July, we're coming back to this, aren't we, in terms of what our next ambitions are and how much further we want to take it. I heard that it sort of relates, and that they were really moving those. I listened to a podcast the other day of Jacinda Ardern, who lots of people will know was the Prime Minister of New Zealand, and she talked about her what she thinks politics is about and what public service is about, and she talked about 4 things. What people need is somewhere to live, something to do, someone to love, and something to hope for. And that really brought that to life, actually, that those actually are the really important things. So, okay, I think we've got to the end of that item then, if there's nothing else that anybody wants to bring up. So, so we were asked to consider the report and note the progress on the good mental well-being. As I say, we're coming back to that in our workshop in a month's time. So, can I have a proposer for the motion? And seconder? And in favour? Anybody against? Thank you very much. Right. Okay. So suicide prevention strategy is the next item. And again, I think that's with you, Lindsay, isn't it?
Thank you. I will hand over to Kristen as well to run through this, but just very briefly to say that this has been a huge piece of partnership work to bring the strategy together. And this is kind of a finalised draft, really, to bring to the Health and Wellbeing Board for information. But obviously, if there are any comments, we'd be very happy to receive them. Thank you.
Thank you. So the Herefordshire Suicide Prevention Strategy will be delivered from 2025 to 2029. The strategy was very much a partnership and jointly developed piece, although it was led by public health. Last year we undertook the engagement, so there were 7 lived experienced interviews. We engaged with 34 organisations, services and partnerships in Herefordshire. So that was through direct conversations, but also those organisations, services and partners worked with any priority groups they already had links with and gathered feedback through those groups. We also provided and produced a anonymous survey which we shared far and wide, so we had 64 responses to that. The strategy aim, so our partnership group were really clear that they wanted a short, succinct strategy that was accessible by all and could be used by everyone. They wanted the language clear and simple. We looked at a number of other local authority strategies and there were some that were certainly more favourable. We included as many local case studies, photos and support information as possible to really localise it. And we looked at what is currently working well and not working so well. We also considered what progress had been made since the last strategy and where there was still work to do. So we created the below vision, which is our collaborative vision, which I'll let you read. And then considering the new national strategy and feedback from all of our engagement work, the following commitments were made by the group. So we have 7 commitments. And our next steps as a partnership, so we're meeting later this week to start creating an action plan to take forward these commitments. And within each of the commitments we have a further 2 bullet points where we kind of focus the work a little bit deeper. So the action plan will be built upon those. And again, the action plan will be very much a partnership action plan. We have really good engagement in our suicide prevention working group, the group which is taking this forward. And there's lots of energy behind it, which is great. Thank you.
Thank you, Kristen. Any questions or comments? I don't think so. The only thing I was, you said this sort of replacing a previous strategy. How successful was the previous strategy? Have we seen the rates of suicide reduce on the basis of that? or what's been happening?
That's a good question. I think there's two parts to that question. The action plan which we took forward from the previous strategy, there has been much change and action taken place, so that's really positive. I think with regards to the data, we implemented the real-time suspected suicide surveillance system 18 months ago nearly now. So we're now starting to be able to monitor the data more closely and look at key themes through our suicide audit group. So the data is coming through more and more. Prior to that, we had less information and less data.
Okay, thank you. Zoe.
Yeah, and I was just going to say on the back of that, in terms of thankfully, we're always talking about really small numbers, but actually the strategy really focuses our efforts in terms of what we know about who's more likely and where we can really do some targeted work around that. And also in terms of that suicide audit reporting, understanding where there might be clusters, etc.
Yeah, thank you very much. Okay, so our recommendation is that the board notes the strategy as an action supporting the priority of good mental health across the lifetime. So proposer, please. And a seconder. Same again. And so those in favour. Anyone against? Super, thank you very much. Better Care Fund. So Hilary and is Adrian joining us?
If I kick off and then I'll leave others to answer the difficult questions potentially. So this item is the Better Care Fund reporting for 24-25. As ever with the BCF submissions, they never naturally or neatly fall with the dates for the Health and Wellbeing Board. So, but we'll try and get better reporting through this current year. So this is the year-end performance return that was submitted on the 23rd of May, signed off by myself on behalf of the Chief Executive and the Accountable Officer for the ICB. There's quite a lot of detail in the report, but I think it's what the report confirms is that we have met all 4 of the national conditions. So we've a jointly agreed plan, we've implemented the 2 policy objectives, and we've maintained that contribution to adult social care and investment in out-of-hospital services. There are 4, or we were reporting on 4 key metrics in the last, in 24-25, and you'll see from the report that we have met the performance, and in some cases substantially better performance against those metrics. I think in terms of the finances, overall the Better Care Fund came in with a small net underspend, which is obviously good. However, I think what that masks is significant overspend in the area of hospital or the facilitation of hospital discharge, which we're well aware of. And whilst the underspend is primarily around staffing, then that overspend was driven by use of care home beds, etc. in the market. And having to buy home care hours as well. I think we know that we've been managed that all through the year, but it's a very real issue for us and continues to be an issue for us. So whilst overall we underspent in the BCF, I don't think we can move away from the fact that we overspent in that particular area. I'll stop there, Chair. I'm happy to answer any detailed questions. And just, sorry, before I finish, just to say that Nicola Williams, who's our new Partnerships and BCF Manager, is here today, who'll be supporting and bringing together the reporting and the unit supporting, particularly around the BCF going forward. Thank you.
Thank you. Nice to meet you, Nicola. Carol.
Yeah, I noticed the changes in this year's plan compared to previously. And the area which I was sort of just requiring some clarification on really, no funding available to increase investment in prevention, community resilience or admission avoidance.
Is that in this year's plan?
Oh, that might be.
Carol, I think
in
that might be on the next
that
agenda
might be the
item.
next one, yeah.
So we can pick that up then. So this is our retrospective look, as you say. I mean, it's good news, isn't it? You know, we've met the criteria, we've met the key performance indicators, and we've come in on budget. So all those things are good news. But Hillary's right. What we've got is a huge overspend on hospital discharge. And again, if we go back to the issue about emergency care, most of those patients are coming in as urgent and emergency patients and then requiring facilitated discharge. If we can do more, which I think comes back to your point, if we can do more around preventing that admission in the first place, then we have less spend onto this budget. And so I think as we come onto this year's plan, I think we'll be able to see quite how tight that is. Okay, so I don't think there's any other questions. So we are recommended to review and approve last year's report and to support the integrated care provision that's funded, and just note that. Oh, excuse me. So, proposer, seconder, and all in favour. Okay, let's move on to this year's. You might give me COVID, Hillary. Come on, move on to this year's plan.
Sorry if I have. That's all I can say. Oh, my laptop's gone. So this report introduces the Better Care Fund plan for 25-26. As you can see, there are new objectives which are very much about supporting that shift to left shift, I guess, from sickness to prevention, and shift from hospital to home, and that's writ large in the BCF for this year. So the key changes from previous years is that all of the discharge funding has been consolidated into the Better Care Fund. There's been more of a focus on trying to focus on outputs over inputs. There will be enhanced support for areas that aren't meeting their targets. And again, the metrics, there are now 3 metrics within the plan, are very much looking at outcomes. They're about emergency admissions to hospital, average length of discharge delay, and long-term admissions to residential care homes. The plan has been challenging to pull together. We have submitted it to NHS England for approval. It was done very much on a partnership basis across the One Herefordshire. But I think it's fair to say it has been a challenge to bring the plan in on budget in line with the funding available. And actually, whilst we all aspire to that prevention, actually that's been still difficult to achieve within the funding envelope. So there have been limited increases in the allocations. Obviously, Simon has spoken earlier about the changes nationally which impact inflationary pressures, and that predicted level of demand means that we've got a really challenging situation and a really challenging plan, and bringing that into balance has required us to take some challenging decisions. So the plan is there. There is, as I say, we are all committed to it jointly across the One Herefordshire Partnership, but it will be a challenge to deliver.
Thank you, Hillary. So, Carol, did you want to come back on that question that you had?
Yeah, but it was the fact that no funding available to increase investment in prevention, community resilience, or admission avoidance. Comes under the bit that says the most significant changes made in this year's plan are, and it talks about the removal of the operational social work teams from BCF, and removal of taught community services, and then it goes on to say no funding available to increase investment in prevention, community resilience, or admission avoidance. Page, I don't know what page is on yours. So could be 315 or 3. It's headed,
Perhaps, Hilary, you could
it's
talk
headed
about...
key changes since previous BCF plan.
Yeah.
Councillor Gandy, I think, looking at that bit on my in my paperwork, that's the... it's part of the national template, isn't it? So the NHS England set parameters for the Better Care Fund, and then we have to complete various sections that describe what we're going to do. I think the bit you're referring to is part of the parameters that have been set, which is a national policy decision to focus this resource on discharge, I think.
Yes, I don't think that's a local decision. I think that's been part of the national conditions.
It was only because the bullet point above talks about the removal of talk community services. These services are focused on community resilience and prevention. Responsibility for them has transferred to public health, and they will be funded by base budget with the BCF funding repurposed towards long-term ASC placements. That's one of the other items.
Yeah, no, you're right.
Yeah.
So Talk Community Services had previously been funded through the BCF, Better Care Fund. We took the decision, whilst we're not disinvesting in Talk Community, but to bring, as that is very much something that the council supports, we bring them back into the base budget. I think where we said we'd repurpose towards long-term adult social care placements, I think that was recognising the pressure we've had around discharge, that we couldn't be in an overspend position, that actually we needed to do something about it. But I think what it means is that we have limited additional funding then to invest in prevention.
That's what I was trying to tease out.
So it's the additionality rather than there is nothing at all.
Yeah.
Clearly, all the work we do and certainly the neighbourhood health and all of the rest of the things that we're doing is very much focused on prevention, but there's no additionality. So the more we can do to work with patients to support that, we potentially can free up then funding going longer term to be able to reinvest.
And also the more that the voluntary sector can do with regards to prevention will help us as well.
But we also have to recognise that the voluntary sector can't do that without some investment as well. So there's about how we work collaboratively together to ensure that we're not that we maximise all of our resources across everything that we do. And I think very much that spirit of how do we bring resources together from which we, by bringing them together, get more than just the sum of the parts, I think is very much the ethos we have to work with going forward.
Thanks, Hilary. Certainly from my point of view, I mean, I really support that move to an outcomes focus. That those three outcomes of reducing emergency admissions, reducing discharge delays, and reducing the need for long-term care those are absolutely the three things that we would want to focus on. So I think that's really good that that's part of the national guidance, and I think is much clearer. I think the other thing is that's also aligned to on Friday the National Urgent and Emergency Care guidelines for the coming year were released, and again it's all related to those to those three outcomes. So it does feel like there's a level of alignment across the sort of national and the local and where we want to go. Okay. Any other questions? So in which case, I think we're being asked to support the plan for this year. As I say, it has actually already been. So we are slightly retrospectively doing this as Hilary notes. So again, should I have a proposer, please? And a seconder? And everyone in favour? Okay, and I don't think there's anybody against. So that's approved. Thank you. I think we're on to the last item of the agenda then, which is the work programme. I think this is really here for information. Is there anything else that we would want in the work programme that isn't already highlighted in this? I say we've got a workshop in a few weeks time, haven't we? Which is going to explore the our two health and wellbeing priorities and our level of ambition about those. So are we happy to approve the work programme for the rest of the year? I think so. Nobody's saying no. Okay, we see that approved. So I think we're on to the date of the next meeting then. So the date of our next meeting is the 15th of September, which is going to be about a fortnight before I retire. And so that will be my last meeting then. So just for information for people, my successor has been appointed. It's Sarah Schindler, who's currently the Chief Nursing Officer at Worcester Acute Hospitals. So she'll be joining the Trust as Managing Director in a couple of 3 months' time. And obviously this group will want to consider whether you want to continue with the same arrangement or not. But I will be here for the next one, so I can say goodbye to you then. All right, I think I'll close the meeting there then. Thank you very much, everyone.
And if we can shut